This week on the BackTable podcast.
My favorite example of bad design is the EpiPen. So in untrained adults, 4 out of 5 unsuccessfully complete injection per the instructions on an EpiPen. And nearly 15% would have injected their own hand if not stopped. And injecting your own hand with epinephrine is not ideal, obviously. Like we all know you can cause skin necrosis, all sorts of side effects, but that's really the main concern. And then there's another study that shows that in doctors, up to 16% self-injected their thumb when deploying a training device. I'm sure at the board meetings, when they started to see these results, inside the company that developed the EpiPen, they were probably like, well, the patients just need to be more compliant.
Yeah.
Or the patients need better
train
training.
them or educate them.
Right, exactly.
Yeah.
But if instead we blame, like I was alluding to earlier, there's several major flaws with the design of the EpiPen.
Hello, everyone, and welcome to the BackTable podcast, your source for all things interventional and endovascular. You can find all previous episodes of our podcast on iTunes, Spotify, and on BackTable.com. Now, a brief message from our sponsor. RADPAD was developed by physicians for physicians. Clinically proven radiation protection during cine and digital subtraction angiography. Don't bet your career or your health on anything less. Trust RADPAD radiation protection shields for all your fluoro-guided interventions. See radpad.com for more information and contact info@radpad.com for a free radiation evaluation and a no-brainer radiation protection cap. And don't forget to tell them that you heard about it on the BackTable podcast. Now, back to the episode. This is Aaron Fritts. We have a great episode today. We're going to be talking about design thinking in medicine with some examples covering interventional radiology, but also other examples that we might see in medicine, even in the cath lab. With us today, we got Gregg Khodorov from Thomas Jefferson, Department of Interventional Radiology. Welcome, Gregg.
Thank you. It's an honor to be here.
Yeah. So, Gregg, you and I met not too long ago. We had a nice conversation via phone. We've had prior Jefferson people on, but previously, Karen Gonzalez, most recently. I want you to kind of give us a quick intro, though. Tell us how you became interested in today's topic, which is design thinking. Give us a little background.
Sure, yes. I was supposed to start medical school right after undergrad, and I was in the U-Haul truck on the way home from, packing up all my stuff and moving back home for the summer before med school started. And then while we were driving in the U-Haul, I got this email saying my med school had over-admitted students. And in order to, I guess too many people had said yes, basically, in that year, and they weren't expecting that many yeses. So in order to sort of alleviate some of that inflow of students, they offered 1 year free tuition if you deferred for a year. And at the time, my partner, who's now my fiance, was going to be doing a post-bac and then applying to med school. So I started thinking it might be nice to sync up so that we could couples match eventually if we're still together. And I had always wanted to get educated in business. So I ended up taking the GMAT in 2 weeks and applying to business school. And so I basically got them to approve my doing an MD MBA, but not in the traditional way where you kind of take a break between certain years of clinical medicine, but rather just right up front. So I got the MBA out of the way.
Yeah.
And in that year, this phrase design thinking kept showing up in our innovation classes and elsewhere. So that's sort of how I got first exposed. And then when I was a first year med student, I was just, Googling design thinking in healthcare. And I remember coming across this medical conference, Stanford MedX, on Stanford's campus. And I started a GoFundMe basically to buy my registration and my flights. And through friends and family who kind of supported me, I was able to go attend that conference, even though I wasn't presenting anything and I couldn't get any, funding through my school for that. And it just really opened my eyes to how important this concept is in medicine in particular, because the whole philosophy around design thinking revolves around the idea of human-centered design, meaning if you keep your end user, the human, at the center of your design process and your innovation process, you end up with better results and innovation that matters, as opposed to innovation that's created in a lab and then attempted to kind of retrofit somewhere in the marketplace.
Yeah.
So that's sort of how I got interested in the topic. And then I kind of brought that concept back to my med school, and I started teaching some of these concepts to med students. I was a co-president of this med student organization called the Biomedical Entrepreneurship Network at my med school. And we kind of just taught innovation concepts and physician entrepreneurship to med students. And design thinking was like a big sort of vein that kind of made its way through that philosophy of how I kind of approached teaching and workshopping with students. And then
I want to stop right there because I want to thank you for defining, design thinking first, because, when I hear that term, I'm not quite sure what that entirely means. Like, my brother, for example, is an industrial design major, and I remember him designing products. But, when you think of design thinking, especially in healthcare, I think a lot of physicians, you probably see this, probably eyes glazed over and they're not quite sure what you're talking about until you really give a nice, clear definition like what you just did. I do want to back up 1 minute because I am curious about where did you go to med school?
I went to Rutgers, Robert Wood Johnson.
Rutgers, which I forget, is that private or is that public?
It's a public med school.
Public, okay. So still substantial savings, right, by deferring a year. Did they pay for your MBA as well?
So they didn't pay for the MBA, but the med school was more expensive. 1 year of med school is more expensive. So I made out with a little bit of profit to apply to my first year of med school after that.
That's amazing, man. That's great. And it's so funny how timing works out like that sometimes, right? Something similar happened with me and my wife, where it just kind of like opportunity sometimes happens so that because we were couples matched, we were kind of trying to be along the same timeline like you and your partner. And it's just funny how opportunities fall in your lap like that. So let's fast forward. You're in med school. You said you were actually teaching some of these concepts to your fellow classmates.
Yeah. So as a med student, I, with a group of, just friends who kind of believed in me, and we all kind of were interested in this same topic of where do physicians belong in the entrepreneurship space. We founded the first Health Innovation Summit at our med school. So we brought in some speakers, and that's still an ongoing thing that it's really cool to see. Actually, this past year, the former CEO of Jefferson was one of their speakers. I was like, wow, that's really full circle for me. But yeah, anyway, at the end of the conference, after all the talks and stuff, we would challenge these students with a design challenge. And it'd be like a quick sprint, basically, over the course of half an hour. These students would just, with whoever's sitting at their round table, all work on the same problem, and through the design process kind of begin workshopping a solution and then present that to everyone else. So it was a cool way to just kind of expose people to the concepts, I think, which are, the thing is with like design and with business concepts, I think a lot of it is intuitive once you've put a name to something. And unlike medicine, where sometimes the results are non-intuitive, most of us have a pretty good concept of what humans need or want. So when you see good design, for instance, I feel like it's really apparent. We all recognize good design right when it happens, but bad design can sometimes just be, it's challenging to notice because you just build a workaround.
I think you and I talked about this before when we talked by phone, was examples seem to be like the best way to kind of get this through to people.
Yeah.
Examples of good design, examples of bad design. It sounds like that's how you were teaching your peers. But for our listeners, can you kind of give a few? You and I talked about them before, but I think you have a couple of favorite examples that you would use to teach.
Sure, yeah. I mean, so one of my favorite examples of good design that everyone recognizes is this company called PillPack. And basically what the company does is it took the concept of a bunch of orange medicine bottles in your medicine cabinet and flipped it on its head and really thought about its end user, right? The patient who's opening this medicine cabinet every day may or may not be in good health otherwise, or good neurologic health or cognitive health, and forcing them to shuffle through hundreds of these tiny labels on these orange bottles. And what they thought about was like, how might we make this a little easier for everyone? And the reason I emphasize how might we is because all good design thinking starts with this question of how might we, and really thinking about, in this case, it would be how might we change the user experience when it comes to taking your medications to increase compliance and usability. And so PillPack is this like roll, like a plastic roll that comes per month, basically on a monthly basis. And every, couple of inches is your next medication in a separate little tear off package that has the time that you're supposed to take it. So you wake up on Saturday and your roll is on a Saturday and it says 10 a.m., take your gabapentin, and you just peel that off and you take it. And then if you've missed the medication because you go back to your roll, this like continuous roll of plastic, and you see that, oh, okay, 12 o'clock came and I didn't take that medication, but it says 12 o'clock, I was supposed to take it. So I think it's more than just making it easier for the patient, it also increases compliance. So that's an example of something that, usually we end up blaming the patient for not being compliant. But if instead we think about blaming the designer of those orange pill bottles and thinking about how we might make that experience better for the patient, you end up with a result that really matters and affects patient care. So that's my favorite example of good design. My favorite example of bad design is the EpiPen. So in untrained adults, 4 out of 5 unsuccessfully complete injection per the instructions on an EpiPen. And nearly 15%, this is from actual literature, nearly 15% would have injected their own hand if not stopped. And injecting your own hand with epinephrine is not ideal, obviously. Like we all know, you can cause skin necrosis, all sorts of side effects, but that's really the main concern. And then there's another study that shows that in doctors, up to 16% self-injected their thumb when deploying a training device. So at some point you have to start wondering, I'm sure at the board meetings, when they started to see these results inside the company that developed the EpiPen, they were probably like, well, the patients just need to be more compliant.
Yeah.
Or, the patients need better
train
training.
them or educate them.
Right, exactly.
Yeah.
But if instead we blame, like I was alluding to earlier, there's several major flaws with the design of the EpiPen. First is it has a completely non-intuitive construction. So in most of medicine, like if you think about a syringe with a needle on the end, the cap covers the needle, right? You take off the cap and the needle's underneath. The EpiPen, the cap covers the button and the needle's on the other side of the device. So right off the bat, anyone who's used to using syringes is confused by this device and the cap situation, right?
Right.
Then on the actual EpiPen itself, there's extremely confusing instructions and they're paired with graphics that, it's like reading a comic book. Like, have you ever read a comic book and then you have to like go back to the start of the page and you're like, wait, I missed something. Like I don't fully understand what happened in the plot here. That's what the EpiPen instructions are like. And then lastly, it's extremely uncomfortable to use and carry. It's like nearly twice the length of an inhaler and a similar diameter, like a little bit smaller in diameter. So if you imagine like a 7-year-old kid at camp who has, an anaphylactic reaction to peanuts, he's not strapping this thing to his leg in like a strange carrying pouch. And, he's not going to be embarrassed at camp, right? So he's just not going to bring it. And that's not his fault, right? That's the designer's fault.
Right.
So,
and it's not that much epinephrine either, right? It's not, why does it need to be in such a large, cylinder?
Yeah, I mean, I don't really fully know, and I'm sure there was some reasoning behind it that I'm not privy to, but if we take that and just apply some of these design thinking principles like I'm alluding to, so there's kind of several steps to the design thinking process, right? There's empathize, which is really understanding your end user, right? And that revolves around interviewing your end user, interviewing everyone else involved in the process, and really beginning to understand that. Then you define the problem, and that's where the how might we question comes in. So you say, for instance, in this case, how might we design a device to increase compliance and safety of an epinephrine delivery system? And then from there you ideate and then prototype and then test and then implement. So ideation is anything is a good idea. It's sort of like a brainstorm mode. And then prototyping is you kind of narrow down and you say, all right, we want to build this one idea out. And that might be as simple as, pipe cleaners and cardboard just to kind of feel out the situation. And then from there, you go on to testing it with your end user and then eventually implementing, which is actually applying like market strategies and bringing it to scale. And each one of those steps, it's kind of like forward arrows between all those steps, but also backward arrows to every step before it, because it's a very iterative process. And you have to be willing to, take your prototype, let's say, and bring it to an end user. And then the minute they say, okay, well, this could be better, or, I don't like the way this is done, you take that back and you start ideating again, right? So you go forward, but you just as often go backward in the process. And that way you are bringing something to market at the end of the day that really matters. And as opposed to bringing something that you think matters to market, like I'm sure the EpiPen designers did, and then realizing that, oh, we actually have a serious problem on our hands here with usability. So there's another device called the AviQ, significantly less adopted, but it actually solves all these problems. Like I'm convinced that there was a true design thinker in the process of making this product. So first of all, in untrained adults, the AviQ has a 99.5% successful deployment, and the cap and needle are on the same side. It's a smaller size, so it's about the size of like a small credit card wallet. And then the voice, there's voice activation. There's like an actual speaker built into the system that takes you through every step, almost like a defibrillator would have in the field.
Yeah, that's what it reminds me of.
So it takes out all the guesswork.
Yeah, I mean, you talk about good design. I mean, you look at how many lives that the AED device has saved just by adding that voice walkthrough, right? And something that can be packed away and in the corner of any building. It's not this big bulky device, right? That somebody's got to wheel out from a closet or something.
And again, the proof is in the pudding with this stuff. So ultimately, your usability is directly related to patient care in medicine. And, we take that idea of human-centered design, which is the whole idea behind design thinking. And when you extend it to healthcare, it's patient-centered design or physician-centered design, or whoever you're innovating for, basically, you put in that X-centered design. And once you start thinking about things like that, and you realize, well, in that case, it would be actually pedestrian, you're like, passerby-centered design, right? Because you just want anybody to be able to use this device and not somebody who's the patient and not someone who's the provider. So you start thinking, what do they really need in order to use this device successfully? And the answer is really foolproof method of taking you through the instructions, right? And most humans are really good at listening to instructions from a voice. Most humans are really bad at reading instructions. I can think of 20 terms of service that I just accepted at face value for different apps on my phone this past month, right? Like it's just, we hate reading.
Yeah, you're not going to read them. Yeah, it's true.
So that's, and I think one way to kind of break it down is I like to really say, if it needs a sign, it's bad design, right? So that's, I think, a really good metric to use. Like, how often in healthcare do you see like a button on the wall of the hospital or a door that needs opening, and you go to push the door and it's actually a pull door, but it says pull, but your instinct is to push it because of the way it's designed. So this concept is called a Norman door, as Norman was a designer, and he basically thought about how doors are one of the oldest technologies, and yet so often in our daily life, we go to pull a door and it's a push door, or we go to push a door and it's a pull door. And, that's not on us. That's on the designer of the door.
Yeah. So give us some other examples of poor design that we see in the hospital.
Sure. Yeah. One of my favorite examples is at my medical school, there was one scrub machine that had like a swipe, like an ID swipe thing where you swipe your ID and you get one pair of scrubs. And the manufacturer's text on the machine said swipe to the right. And it also said barcode up. And then handwritten next to that was another sign that said barcode down. And like a pen, someone took a pen and basically just like went back and forth a bunch of times and made an arrow in the other direction that the manufacturer had put on the device. That's actually the true way that you operate this scrub machine.
Gosh. Yeah.
Right. And I love that example because if it needs a sign, it's bad design. If it needs a handwritten sign on top of the manufacturer sign, it's really bad design, right? Like that is just the worst user experience. And we might not think, a scrub machine access affects patient care. But at the end of the day, if your scrubs are soaked, you scrub out of a case to change your scrubs, and then you encounter this design travesty, you're really hitting patient care, like you may be delaying care and your ability to get back into the case. And that's like a really simple and obviously extrapolated example, but bad design affects patients all the time.
Do you think part of it is just the technology maybe doesn't exist at that time? Because right now we think about like our phones, you can just like tap everything. You don't even have to swipe your credit card anymore. And the same thing with like doors, right? A lot of doors are now just automatic. You don't have to think about push or pull it, just motion detector and you walk through. Do you think it's just technology not keeping up? Like in terms of like, the scrub machine, my scrub machine acted the same way. It was not easy for whatever reason.
Yeah, I don't think so. I think ultimately, if you keep the end user and their experience at the center of your design process, no matter your technical limitations, you'll come up with a product that's usable. And that has pervaded society from the very beginning. You know what I mean? Like, doors have literally been around for millennia at this point. They're probably one of the first things to ever be built. And the fact that we still every once in a while walk through a door and push it when we're supposed to pull it is just, it's just laughable. Like it really is. And if you think about now, I'll give you a better example. Okay. So let's say you're going through a door and you've got a patient to push and they have a stroke and you're taking them to the interventional neuro suite to perform a thrombectomy where every second counts, and you're encountering this door and it shaves off 3 seconds of your time. When time is brain, seconds lead to minutes of delays of care. And so I really do think that it's one of those things that much of our built world doesn't keep the end user at its core of its design process. And that's really what I'm passionate about.
So tell us what's going on at Jefferson. Like, tell our audience also, we didn't cover it in the beginning, like where you are in residency and sort of how you've integrated this into your training and also trying to implement projects at Jefferson.
Sure. So I'm a PGY3 IRDR integrated resident at Jefferson. And so the first thing I did was when I was an intern, we had like a weekly surgical didactics conference. And I thought that was a really good opportunity to kind of touch a specialty that I wouldn't end up in. So I presented this at one of those didactics to like all the surgical residents. And then it was kind of on me for doing that because it ended up leading to just text from every surgery resident for the rest of the year about like just bad design in the hospital. So I ended up with like this massive repository of, just little things, like things that we usually find a workaround for in the hospital, but everyone kept being like, hey, we should think about this or we should think about that. And it's funny, like once you teach these concepts and you point it out to people, they really start noticing that bad design is pervasive. And that's not a commentary on the hospital system or its delivery of care, but in some ways it does affect patient care. So it is important. So after my intern year, I began thinking about how to kind of use the resources at Jefferson. So a lot of healthcare design forefront thinkers are at Jefferson, luckily. So Bon Ku and Rob Pugliese run the Jefferson Design Lab. I believe the technical name is the Health Design Lab. And this is actually a physical space that teaches medical students these concepts. So I started thinking about how I could incorporate some of that into the interventional radiology department. And I landed on this project where some of the design school students who are not in healthcare, they're just industrial design students, they rotate through the Jefferson Health Design Lab and they want to be exposed to healthcare. So I had 2 students come in. We got them, they already had the clearance for the hospital because they're Jefferson students. And I just had them observe in the interventional radiology suite for several sessions, a couple hours at a time. And then in the process, they're building empathy. They're building that empathy that's the core of the design process. And so they spoke to our techs, they spoke to our nurses, they spoke to our faculty, and they spoke to our residents. And they also just watched some cases happen. And their insights were remarkable. So a big part of, I think, design thinking in healthcare and realizing those things that we all just learn to work around, but ultimately delay our ability to provide efficient care, students pick up right away because they're just like, wait, why do you do things like that? So one great example is our built-in lighting in the ceiling. If you bring some of that ceiling mounted equipment in the angio suite, so like let's say you're moving your II a little bit, you could hit a certain position where the lighting is completely blocked by the II and you end up with lower lighting in the room for whatever duration of time that is. And if at that moment you have to suture or hold pressure or see if there's bleed back or something like that, that ultimately affects the case.
Yeah.
And so they were like, why did you guys build this room with lighting that would be obstructed by your equipment at certain angles, basically? And, we've found workarounds for that. We have that same ceiling mounted equipment. We have like a spotlight that we bring in.
Right.
And they were like, it's kind of silly that the one thing you definitely need lighting is like obstructed by this equipment at certain angles. And so that's not something that's easy to fix in a room, right? Like the ceiling mounted lighting is staying there until that room gets torn down, basically. But
yeah,
it does give us some insight when we start rebuilding or move to a new building or a new area of something to really think about and try to improve.
No, the lighting thing's a total pain in the butt. I mean,
yeah.
I'm constantly asking the nurse to bring it over, like even just for a Mediport, suturing a Mediport up. And they're like, oh, and then sometimes the arm is like in a weird position because of where the C-arm is and they got to bring it around. And it's not functional at all.
Yeah.
In most of the labs that I work in, lighting is like one of the worst things. And again, I don't get it. Why was it designed that way, right? We're here to do procedures. We need lighting.
Yeah. It's just fascinating. Once you start thinking about this stuff and like really opening your eyes to it, you realize just how many workarounds we have in the IR suite. And we even in training, we get taught these workarounds, but many of us are not cognizant that we're even being taught workarounds.
Right.
You're basically just adapting to your poorly built environment in some ways.
Right. And losing efficiency along the way.
Right.
So anything else that these med students have uncovered by observing?
Yeah. And again, they're not med students. They're just design students.
Oh, design students. Sorry.
So they have no healthcare experience.
Okay.
Yeah.
Yeah. Interesting.
So that's part of the fascination is that, and I think it's important to the design process, is bringing in fresh eyes who are not used to seeing the workarounds that you and I just have learned to adapt over our many years of, training in medicine.
Yeah.
One other thing that they noticed is our use of the sharps container is variable dependent on the attending. And no one is unsafe. Everyone, protects their sharps, puts them all in one place. But some people really like that foam box that you put the sharps into.
Yeah.
And then other people don't. And not having a uniform approach to that is theoretically
dangerous.
Yeah, it has some danger to it. And I'm not saying, again, that there's dangerous practice at our institution, and I want to emphasize that, and I think everyone's really safe. But by nature of not being uniform, there is some risk. So they found a bunch of other alternatives that might work better. And there's some that are already built, but just not adopted because of cost or because they just don't come in the standard kits, and you have to ask for them actively.
Yeah.
But there are other needle holding solutions, but most IR suites don't have them. So that was kind of an interesting insight. And if you think about those two insights from these designers, I like to point those two out in particular because the next step in the design process was me sitting down with these students and the design lab and thinking, okay, where should we focus our efforts? So you found a bunch of things that might need improvement.
Yeah.
Obviously, we need to prove that they need improvement. So that comes with looking at KPIs and really understanding the metrics associated with some of these inefficiencies. But then at the same time, we also need to kind of realize what we can and are not capable of improving in the short term versus the long term.
Right.
So that lighting example, for instance, so we basically took an X and Y plotted graph, and on one axis we put effort, and on the other we put impact. Right. And then we took all of these solutions that they had come up with, and we basically plotted them on this graph of high effort, high impact, high effort, low impact, low effort, high impact, with the ultimate goal of being our first effort should be focused on low effort, high impact solutions. Right. That's sort of like your creme de la creme. That's like the easy, low hanging fruit that you can solve and improve immediately. So that Sharp solution, for instance, was one of those low effort, high impact areas. And then it's just a matter of, getting everyone else on board and actually applying these solutions. And that's actually the trickiest part.
Yeah. Well, I mean, let's tackle that because as we know, it seems like hospitals and healthcare is getting more and more admin heavy. We have to get approval for everything, it seems like these days. Academic centers can be just as bad, if not worse. What are you seeing in terms of resistance when you present these problems and potential solutions?
Yeah. Well, I think resistance will always be there. And I also think it's difficult, right? Everything, even getting a device that's approved for an indication to be brought into the hospital system you're working in is like climbing a mountain, right?
Challenging.
Yeah, it's extremely challenging. So then getting people on board with non-billable changes, like changes to workflow or efficiency, it's a tougher use case, right? Like you really have to show people the proof in the pudding, like I said earlier, and the money talks. So finding key performance indicators, KPIs that work really well is challenging. And I also think that even in the case where you do present all the data and say, okay, we'll save X amount of hours and we'll save, Y amount of overtime pay for staff and Z amount of, we'll be able to increase our procedures by Z amount per day. Even when you present all that, it's obviously really challenging, but there are things you can do as a trainee to impact that. And I think that's as simple as, sending an email to leadership. And I think most committees in our department welcome resident sit-in. So they kind of welcome residents to kind of sit in and if they want to, and obviously depending on the committee, but that's really where you can make the difference. So for my trainees out there, I think that's really the first step, is to figure out who's making these decisions and how might I impact them, or at least, bend their ear a little bit.
Well, you bring up a good point, and I remember this as a trainee because we were trying to make some changes at our hospital. You really need like an attending kind of champion, right? And whether that be a mentor of yours or just somebody who sees what you're trying to do and believes in you and is willing to kind of go to bat for you with the admin, help you present it to them, or even take the information that you've gathered and present it themselves. That would be my advice for a trainee, just having gone through that again as a resident. And would that be, it sounds like that's kind of what you're getting at in terms of it's hard to do from the trainee perspective, it sounds like.
Yeah, for sure. I think that's just the sort of hierarchical nature of what we do. And I think that's with good reason too, right? So yeah, I might see the needle holder as a big issue, but then the leadership might think, we have a very low risk of needle injury. We've got basically no data to support that this will make any sort of meaningful change. And we've been doing it this way for, 20 years. So, and no one gets stuck. So why do we need to invest our efforts, let alone our money, into making this a reality? That's the inevitable battle with this stuff, but that's what makes it meaningful and worthwhile.
Well, it even goes along with like older attendings. It's just like, well, that's the way we've been doing it. I don't see any problem with continuing to do it that way. And you have to educate them like, well, there's a better way to do it, and it can lead to better patient care. Just for example, when I was training 12 years ago, some of the attendings were resistant to doing access under ultrasound because they weren't comfortable with it. And it's like, no, this is the safe way to do it. You can actually watch your needle go into your vessel. Like, why would you not do it this way? And they would have some excuse for why, this is a way we do it, and you have to be able to do it by feel. And now, fast forward 10, 12 years, it's reckless not to access a vessel under ultrasound, right? And so I always kind of think of that when it's just, when you're facing resistance from maybe not even admin, but just an older generation who their answer can sometimes be just, well, that's the way I was trained. That's the way we've always done it. There's no reason to change. Well, yeah, there is when you can improve, especially when you can improve patient care, right?
Right. And again, most of my efforts have been focused on the internal improvement, aka entrepreneurship space, right? So that's making a difference from within your institution as opposed to entrepreneurship, which is much more external. And, you could just say, okay, I see this as a problem. The market will bear out that it is a problem. And if I just build a solution, people will start adopting it. And I think the design thinking process applies to both of those principles, obviously. Like the same idea of going through these steps, being iterative, really keeping your end user in mind is critical to entrepreneurship and entrepreneurship.
Yeah.
The problem is that entrepreneurship is actually sometimes much harder to kind of move things along because you end up hitting bureaucracy of a large institution as opposed to being agile on your own and being able to just decide that something needs to happen, right?
Right.
But if you see a problem from within, it's meaningful to make those changes. And I think people generally, when I approach our leadership about these sorts of things, people are interested because if you build the use case for it and you say, this affects patient care, our leadership is really interested in that. So I'm fortunate to be at an institution that actually hears out its residents in this sort of capacity.
Yeah. And so I know you've spoken about this, you've given talks. How can others at other places implement a design thinking approach? And any resource recommendations that you have?
Yeah, sure. Well, I think if you're going to start working in this sort of space, it's important to recognize your own biases, just like when you start research, and think about bringing in someone else. So if you're at a large university that has like a biomedical engineering section or even like a design school, like some schools do, it's worth reaching out to those people and saying, hey, can you just come take a look and see what's going on here? And I can teach you everything you need to know from the clinical perspective, but I'd really like an outsider's view on what we're doing wrong or like how we might improve.
Yeah.
I think that's truly invaluable. And, a lot of residency programs are associated with large universities, so that's not an insurmountable task. It just takes an email. And then getting, obviously the department on board with something like that is a whole nother beast, but most program directors are interested in QI projects for their residents. So if you pitch it as a QI project, that's kind of the easiest way to do entrepreneurship work. From the entrepreneurship perspective, obviously it's like institution dependent on the policies around that and being really clear with your time devotion to that, whether it's in the hospital or outside, kind of dictates ultimately who gets the IP around that. So that's a whole nother separate topic. But
yeah,
I think if you see a problem and you have a hunch that there is a solution to be had, then going through this design thinking process, you don't necessarily have to have the solution up front. These exercises, which are easily accessible, there's lots of books. I really like Ban Ku, the guy who runs our design lab here. He's an emergency medicine physician, and he runs a design lab podcast that you can look up. And then there's also he and Ellen Lupton, who's a really fantastic designer, wrote this book called Health Design Thinking, and they summarize examples that they've done with their students in that book as well, which I think can kind of get the juices flowing.
Yeah.
And then as far as process goes and innovation, there's a lot of resources out there. So one of the resources I used in med school is Google Ventures has a design sprint model that's like 2 weeks basically, and it's structured. There's exercises you do every day. A lot of it is done around a whiteboard and sticky notes, or a virtual whiteboard with sticky notes, and just kind of moving things around and feeling out what's right and what's wrong. And then get a group of people who are just as passionate as you and say, hey, can we go through some of these exercises? And if you pitch it as academic activity, so either as a QI project or as like training for your residency, you can get the whole residency involved in this sort of stuff and move things along. So that's for the trainees. And then, obviously, I think as an attending, that process gets easier. Just get the whole department on board and say, let's go through some of these design process. You're shaking your head. You're like, I don't know if it gets any easier. From my perspective, it seems like it would be easier, but I don't know that that's actually true. So.
Yeah. In academics, it could. I think, like you said, I think it's recruiting like-minded individuals to get involved. That I think whether you're a trainee or an attending, because even attendings can face resistance from their peers, like, hey, why are you spending your time on this? We got more permcats to do. It's one of those things where you got to find a team of people who kind of share an interest so that it gets more importance that way, I think, when you have more people involved. I completely agree with you, and I want to know anything else to leave our audience with in terms of design thinking.
Sure. Yeah. One other book I wanted to mention, first of all, is this is Service Design Doing. It's a book based around research in service lines. If you think of healthcare as a service, a lot of their exercises, and that book is purely activity based. It's like, do this exercise with your team to figure out the next steps. So that's a really good resource as well. So in terms of final thoughts, I think design thinking is a scientific process at its core. A lot of it has to do with research and gathering of data, but then there are also creative elements to it, which is one of the things that I really love about it as someone who is a self-appointed creative. I love that you can really just brainstorm and think through radical solutions, and no answer is wrong until it is. So that to me is really rewarding. And if you just keep the end user at your core of your process as you iterate, and in healthcare, that would be the patient if you're innovating for the patient, or the provider if you're innovating for the provider, et cetera. If you keep that end user at the center of the process, you end up with a fully baked solution by the end, as opposed to a solution that you then have to go back and figure out how to make usable. I'm really passionate about this. I think that ultimately we are all designers, and bad design leads to bad health outcomes in medicine. And so if you see a sign somewhere It's bad design, and it's your job to figure out the solution to that. And it's on all of us in medicine to take that onus on and note our workarounds and then try to solve them. Like I said earlier, we all know good design when we see it, but you feel bad design when it affects your life or the life of your loved ones. So that's kind of, I think, what I really want to reiterate. I will say that the RFS has done a really good job of exposing students to these concepts, and there's a biodesign competition now, and we led a team through that this year as well at Jefferson. So it is exciting. I think the new trainees get it and they want to make changes, and I think it would be really cool if at SIR in the future we had like a design thinking session. Imagine all those great IR minds in one room thinking through some of these problems and solutions. I think that'd be really awesome.
Yeah, I mean, kind of like the M&Ms, right? I mean,
Right.
Those are some of my favorite sessions at SIR is showing a complication and then basically opening it up and everybody kind of talking through what could have gone better, how it could have gone better. It's the same concept, right? Just showing, okay, look at our lighting, look how bad it is. Can anybody tell us, how did you design something better? And like, how do we present that to our admin to make something that's improved upon? So I love that concept.
Yeah, for sure.
You know? All right, well, Greg, we'll wrap it up. Thank you so much for coming on, and thank you to our audience.
Thanks again for having me.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Aaron Fritts, and co-hosts
Chris Beck,
Sabine Don,
Michael Barraza,
Jacob Fleming,
and Ali Behetti.
our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles, Nick Shellcross.
and Ness Smith-Savadoff. Design and digital marketing led by Brian Schmitz.
Article and transcript support by Taylor Robinson.
And Delaney Aguilar. Social media and PR by Ann Dang.
Administrative support provided by Jamila Kennebrew.
Intro and extra music is Ripperoo by Skeptic Moon. Find us on Spotify or at local live music venues in New Orleans, Louisiana.
Thanks again for listening.